I need to defend myself. On the evidence-based medicine stuff, Professor Roark told me that there's lots of questions about what to do with that. And, you know, unfortunately, even though Dr. Bonata's in Italy, while this test is being put together and given, he's in Italy. He's in Villa. I talked to him on the phone yesterday, and I said, I've got a couple of words for you. I could say, like, Pazon, you know, chow, spaghetti. I say Roma. But there are some things you will have to know, and to rank your anxiety from here to here, you are going to have to calculate. But I will tell you what you have to know. You do have to be able to calculate this test. It's what he really wants you to take out of here. So there's two things you went over. One you went over was terminology and definitions in clinical research. You need to know the basic definitions. What is the odds ratio by definition? What is the hazard ratio by definition? You have to know those. I can tell you right now, there'll be 4 questions off of this. There'll be definitional type things. Do you know what stuff is by definition? Okay? On this other one, this diagnostic test, he really wants you to be able to do these calculations in the head or think about them at the bedside for diagnostic tests. I know he went over this with you. If you do a history and physical and you think some disease is, you know, is like 50-50, they've got it, versus 80% they've got it, versus 20% they've got it. He gave you those examples, and you went through the calculations with that. Then if you have a lab test, and you know what the likelihood ratio is for that, then you should be able to figure out how does that change your notion that that person is positive for that disease. So 20%, you know, might go to 30%, you know, 50% might go to 75%. So you have to start using your lab test results with your history and physical. He really likes you to be able to do that, and that is basically what you're going to be asked to do with the article, you know, that you have to go over and do the review. You have to be able to use pre-test odds, what you think something is, and he broke it down in 3 categories. You don't think they have it, you think it's 50-50, you think they have it. So it's 80%, 50%, and 20%, and he worked through those calculations. Then he gave you likelihoods ratios, positive likelihoods ratio, negative likelihoods ratio, and how to then use that information, your bedside pre-test odds, using a likelihood ratio, what is your post-test, you know, odds that they have this disease. That he likes. There's going to be 2 calculations on that. I'm going to write them. They are exactly like he's already done in his handout. You know, there's a 4x4 table. I'm not going to ask you to be able to calculate all that stuff out of that table. But you do have to know how to take pre-test odds. And I will have to give you what likelihood you think something, you know, what odds you think something exists. You have to be able to state, given a likelihood ratio, what their post-test odds are for having a disease in question, okay, based on a positive likelihood ratio, and you have to be able to do one on a negative likelihood ratio. You think it's 50% when you do physical, and you do a test and it's a negative likelihood ratio, then it goes down. Does it go down enough that you don't worry about it, or is it negligible? That I'm not going to ask you to decide on the test. But I need you to be able to take the numbers and do the calculation. Does that make sense? It's that straightforward. It's not going to be, let me find a way to take the numbers to trick you. Let me create bizarre tables and have you do all this stuff. I'm not really going to ask you to expect you to do that, but I do expect, and I know Dr. Bonata expects, that you take pre-test odds based on history and physical, a given likelihood ratio, which you can look up. He really tried to encourage looking it up on your electronic devices. And if you could find that at the bedside, then can you work with that? Can you work with that standing up without having to go do literature searches and all the hullabaloo, you know, that you could do? That he wants. That's a take-home skill. That's an in-the-clinic skill that he wants you to have. Okay? So that's where the question comes from. So you'll have 4, and I'm telling you right now, if you decide to throw 6 of these, that's fine. They are all tagged as intro to profession, so they are not concentrations that are impacting, you know, the ones that are measured for advancement. Okay, it's very much like back in the first course I gave you an overview of evidence-based medicine. Those questions were all tagged as intro to the profession. They're there, they have a label, I can follow them, but they are not a concentration that we evaluate at the end of the year, and if you don't do good in it, you're in trouble somehow. But they do count towards the test grade. So if you're sitting there and everything you know is about 71%, and then you miss 6 more questions, you could fail the test because you don't know it. Or you can improve your overall score because you know it. It won't mess you up in any concentration assessment, but it could mess you up for the grade in the test, which could mess you up for the grade in the course. Okay, so 6 questions. I figure this first test is probably going to be 100, something like that, 100 maybe. So, what's that?
It should be about 100.
Yeah, it'll be something like that, just looking at what you had done, so figure it out. But it is something you need to know, so I wouldn't just pass over it because it's going to show up repetitively in evidence-based medicine. And we very intentionally held off on this. You know, last year we were doing evidence-based medicine with the first SPBL. I felt like it was too much. So what we want to do is get you comfortable with history taken, physical documentation, and now we're trying to layer in more things you think about when you see patients. So the summer is the launch of the EBM in practice type thing. And it's stuff that you'll need to know. It's stuff you'll need to understand. And honestly, I think here it is about as practically put together as it could be, because it's a whole to-do. If you've ever been in any curriculum where you've done drug study design, epidemiology, biostatistics, in a practical sense, there's a lot of stuff, and we brought it down to here's bedrock, okay? Does that make sense what you need to know? And if it doesn't work out that way and you end up missing all the questions, we'll just blame Dr. Banana. Since he can't defend himself. Okay, and that'll be about a fair balance because the other assessment actually comes from reading the article. Okay, that's another piece of how we do this. So I don't need all the questions on the test to do it.
See, and I don't think they have this, so I may go.
It's in that primer.
Is it in the primer?
Mhm.
Okay.
When he went over,
Page 21.
it's 21 through 26. When he went over the class, he actually was doing this.
Right.
When he was up on the board, he gave you 20%, 50%, 80%, did his calculations. This is it in print. It's posted.
It is, so that's been 75 pages long.
Yeah.
So
I'm telling you, 21 and 26, and very specifically, you can read 21 and 26 to give you some background, but it all reduces down to what you pull off of pages 24, 25, and 26, and it gives you the calculations. It walks you through what you need to be able to do. Okay? If you have any questions, you can send them to me. I'll pay attention, but it will be very fair, very straight down the road. It's something you have to be able to do. Okay? That's about as good as it gets. Okay? Now you know.
Thank you, Dr. Britton.
Thank you. Yeah, and now, having said that, now we'll go in there and write 10 questions and read 13 calculations and say, oh, I just got excited. Just keep going.
That's what we normally do. I'll do the task by the
We need to order them garlic, onions, spices. I know it's spicy.
You have a table of UC, ulcerative colitis. I did this last year. I did some update. Again, it's always for you to take and use it however you want. You can add, do whatever. This is like basic. So it goes over location, remission, alternate therapies, and then it goes over maintenance issues. Do you treat the first time? Do you put them in on drugs to maintain or not, based on severity? Okay. All right. To me, UC is pretty easy. Crohn's is a little bit harder. So the first thing, when you see somebody acutely, and besides taking care of other things that need to be addressed, you want to induce remission. That's our big goal. And it's going to depend on where's the problem. So we're going to start with proctitis and proctosigmoiditis. So again, we're going to use mesalamine products. And if it's proctitis, we're going to use topical. That's our preferred. And we're going to use suppositories. Most of these folks can be put into remission with that drug alone, single agent. 90% of them will go into remission. Mild to moderate, they have a good chance of staying in remission for, that may be the only other episode they ever have, or they'll have very few in far between. So suppository for proctitis. If it's proctosigmoiditis, then you're going to use an enema. And these will usually be twice a day until you get to about 8 weeks. Okay. So they should respond quickly. You should expect that in the first 2 weeks they have reduction in symptoms and they're feeling better. And then you're going to continue it for about 8 weeks to allow healing to take place. If they don't respond, then you can add a steroid. So if you go down to like the fourth bullet, topical ASA is superior to topical steroid. So in UC, we're going to start with this drug, and steroids are only added on when people can't tolerate the mesalamine or they have an incomplete response. So decreased response, we'll add a steroid to that. We'll keep using the mesalamine. If they cannot tolerate the mesalamine, we'll move them to a steroid. And if they can't tolerate topical, then we'll move them to an oral. But the ability to respond or to cover it or to treat it is much less. Okay, so that's the progression. Topical, mesalamine, dosage form depends on where the disease is. Incomplete response, add a steroid. Can't tolerate topical, we move them to oral. Okay, that's the progression. That's all. That's a summary of what is written on that first page. 90% of people are going to go into remission. If it's their first episode and it's mild and it's proctitis, we don't put them on a maintenance. That's on the top of the next page. Because if they have episodes that are several years apart, we just treat those separately or individually, instead of subjecting them to a drug forever. Now, what do you imagine the adherence with rectal administered drugs is? It's low. Okay. So that's one reason. The other is for people who have proctosigmoiditis, they need to be on maintenance therapy. Okay. So beyond the rectum, we're going to put them on maintenance. Or if they have multiple flares, let's say they have 2 a year, then we would consider putting them on drug all the time. When we're inducing them, we'll usually use those topical products twice a day. And then once we get to the end of that 8 weeks, we're going to try to titrate them down to once a day, mostly at night. The longer they can retain the drug, the better the effect they get. In the past, they have looked at intermittent therapy. They've looked at, okay, if it's mild and we'll just have them treat whenever. They have found that that does not maintain as well as nightly. So the recommendation now is to use them on a regular basis, every day. Questions? The very last section at the very top is if people have been in remission for 2 years or longer. and without any flare, you could consider tapering them off. Or if they say, I don't want to take meds anymore, it would be reasonable. Okay. Let's see. I think I covered all the other. Oh, under maintenance therapy, that third bullet. So your progression up is going to be topicals. In maintenance, we don't want to use the steroids. We want to stay with the ASA products. So if they are having relapses on topical, always check adherence first. Then you could consider adding an oral agent on top of that. Any of them are fine. They are all considered equally efficacious. So it may go to what does their insurance pay for, what can they afford, what do they tolerate. Some of them are once a day, some of them are multiple times a day. If you look back at that chart, you'll see a lot of them are 3 and 4 times a day, especially in, look back at page 9. So if you look at exolpidine, it's 3 to 4 times a day. Same with Pentasa. Apriso is once a day, but you can bet it's more expensive because of that. But most of them are going to be in that 3 times a day. So that is hard on adherence. So if you can move them to a once a day and it works for them, then that would be great. In case you don't know what enemas look like, or the foam enemas, here's how they come. They're usually in about 60 mils, so a couple ounces. The foam is usually not. Usually, you're going to use a foam if they can't use the enema as well. Again, the enema is going to get further up the colon. They have adapters. The foam comes with an adapter that they use. Okay, just in case you've not seen those. Okay. So let's look at mild to moderate disease if we've got distal disease or hand colitis. Let's look at that one. Here you need, because you've got areas of the colon that are not going to be covered by topical, then you're going to have to use an oral to start with. So we're going back to inducing remission. So if you look at the top, you're going to use a oral agent, because that will get the whole of the gut, and 2 topicals. You'll use a topical ASA or steroid, and a steroid enema or foam. So these are 3. You've got more extensive disease, so more drug. So this is to induce remission. So tablet, enema, the ASA or the steroid suppositories and the steroid foam. Again, high remission rate. So this group of drugs very likely to cause them to go into remission. Any of the mesalamine products are good. Some studies prefer that mesalicide because it's the one that gets cleaved in the colon to mesalamine. Let's see. Response should be again in about a couple of weeks, and you're going to continue it for that an 8-week total, again allowing the gut to recover and to heal. If patients don't respond to those topical steroids, then this is when you would consider that Uceris. Okay. Remember, it's a steroid and it is designed to release in the colon. Okay. It's for remission only. If they do not get a complete response, or for some reason they couldn't tolerate, you can use prednisone. Prednisone is very powerful and it will induce a remission. It's just we don't go to it because of the side effects. So these you use, I don't know what dose did I put, 40 to 60? If you look, no, I think it's 40 to 60. Back on page 12, 40 to 60, so about 1 milligram per kilo per day. You're going to leave them on that for about 10 to 14 days. Then you're going to start a very slow taper. So it says to reduce the weekly amount, or on a weekly basis, drop them by, what is it, 5 to 10?
Mm-hmm.
Okay. So the thing when you start reducing them, flares are possible. So you can always up the dose again and decrease them at a more slow rate. Let's say 10 is too much. So you can go back up and then start the taper again with a lower amount. I think they recommend going down on a taper to get to about 20 milligrams a day, then you're going to slow the taper even more. The goal is to get them entirely off the steroid. So the slow taper is, for the most part, it's the flares that we're trying to avoid. Okay. All right. These folks will all go on maintenance, so there won't be any question here. Again, the mesalamine products are very good at maintaining remission. Here is where I put that, at least from the different things I read, is that usually 3 grams a day of mesalamine is what is recommended. If you go back and look at the doses that are usually listed for remission, for maintenance, they're a lot lower than that. But most of the studies, or the things I looked at, said about 3 to 3.6 grams a day. So you can upward titrate, leave them at where they were for remission, because we use those higher doses, and slowly work them down. These drugs are well tolerated. Most people are not going to have a lot of problem with them. But we'd always like to stay with the dose, the lowest dose that maintains them. We are going to avoid oral steroids for remission, or to maintain remission, for maintenance. Now, you could, though, remember we talked about for people who, even though they have pancolitis, if they have tenesmus, did you know that term? That urgency, then that, what?
You want me to tell you what it means?
No. No, that's fine. So there, you could use the steroid or the other suppositories to maintain them. Okay, so the topical you'd go to once a day, usually at night. The longer they can retain it, the better. Symptomatic treatment, so here's where you could use other things like loperamide to help with diarrhea, for the cramping, the anticholinergics that we just talked about, like dicyclamine or hyoscyamine, any of those. Opiates you want to avoid because they can mask underlying or problematic, and then avoid the NSAIDs. Okay, so that's mild to moderate disease. So fairly limited, mostly it's, again, dependent. What did I tell you? Oh, let's go back to this. What have I told you that's the most important takeaways? Where the disease is happening and how severe it is will drive what you treat. Okay. Drugs of choice are what? Mesalamine. And steroids, what's the caveats there? Don't use them long term. Where do they belong? Remission. Okay. Topical versus oral. Okay. So ask yourselves, when you're going through, if you will start to ask yourselves, what is the big message I need to get out of this, then you're probably going to hit mostly what I am going to test you over. So ask yourselves those things. That's where I see you all missing on at least the Pharm, is they are big concepts. Either you decide to chuck that section, but eventually you'll have to come back and look at it. When Dr. Britton and I were in graduate school, I cannot tell you you think I give you a lot of paper, you should have seen this stuff, because we took the second year medical school curriculum, and then we had our own Pharm D curriculum. I am not lying to you that when the psych people came in, they brought it in on like one wheelbarrow. It's those things, those little tractors that you use to pull these pallets of stuff. The initial was 8 inches, 8 inches of paper. It's the only subject I really ever just hated, and I burned every bit of it. I disliked it so much. It's the only thing. I even still have all my notes. Anyway, so we're going through cardiothoracic surgery in the medical school. It's like, oh my God. No, it wasn't cardiothoracic. It was the OBGYN. And we got to adnexal masses. And Dr. Britton said, I can't take it anymore. So he just threw his adnexal masses. He said, I don't care about them. I don't care to know about them. You don't know what adnexal masses are? Oh, you don't even know. So they're the masses in the pelvic area next to like the uterus or the ovaries, adnexal masses. So anyway, so we would go through and figure out, we're not going to learn this. We're not going to learn this. And so adnexal masses are always kind of our code word for things that we are not going to do. I do know you go through and just selectively decide what you're looking at. So anyway, but if you will look at those big take-homes, then usually you're going to get the things that I'm going to ask about. Okay, let's look at severe and fulminant. So severe, you're going to throw everything at them. So for the severe, you're going to use an oral steroid. So this is the first time they really show up a lot with in UC. So it's oral steroid, an oral mesalamine, topical mesalamine. Usually, you're going to use a foam. Suppository and a enema. So we're using almost everything we got at this point. We're going to try to get rid of drugs that are aggravating the underlying cause. So they're listed there, anticholinergic, antidiarrheal. So maybe they've been on it, or maybe they've been self-treating. That's another thing to look at. Non-steroidals, opioids. Try to get rid of those things that may be causing the underlying. They also put them at risk for that toxic megacolon. IV antibiotics may be needed if there's an indication. So if they've got toxicity, so the fever, leukocytosis, those things that tell us that there's an infection would warrant the antibiotics. Bowel rest is usually not recommended for this level of folks. If they are malnourished, they can't keep things down, they can't eat, then using enteral feeds would be the preference. If they do not respond to these and you have to admit them, there's some special things to keep in mind. If you go down to the third, is that these folks, regardless of being put in the hospital and being put at bed rest, are at increased risk for thromboembolism. So these folks need to be prophylaxed. Okay, so they need to be put on a heparin. So they need to be put on an unfractionated or low molecular weight. They have a higher incidence of clots than other diseases that we admit to the hospital and put at bed rest. For those who don't respond, you can use IV steroids. This is the one place where that would come in. You could also put them on cyclosporin. It's a very good induction remission. So when people have flares, you almost start over again. You're going to go back to your remission drugs to induce remission and start. Cyclosporin is very fast and very powerful. We just can't use it for very long. You could also use one of the TNF-alpha agents as well. So for maintenance, we're going to go back and we're going to take them off the IV steroids and we're going to convert them to oral steroids, and then we're going to do that slow taper again. You can go back to the drugs that worked before and reinstitute them, working to always get them off the steroid. Keep them on the oral mesalamine and the topicals that they have been using as well. If they continue to relapse, or you can't get them off the steroid, that is where, in this disease, that you would use an immunosuppressant. So like the thiopurine. So the thiopurines are azathioprine and 6-mercaptopurine. Remembering that they take a long time to exert their effect, up to 6 months. So that you want to get them started early if that's what you think they're going to need, and so that the steroids will help that, they'll be that bridge. Or the TNF-alpha could also be used. They also take a while to exert an effect. Fulminant, these are the very, very sickest folks. They are the highest risk for toxic megacolon. They're admitted to the hospital. If they do not respond to these interventions, then these are the folks that usually are going to be the highest candidates for colectomy. So if you look on the other side, these folks you would put on NGO, these folks you would have on IV steroids, you would use cyclosporin, and then you could use infliximab as well. But if they don't respond within like 4 to 7 days, or 72 hours, this is where I don't know this as well.
If they have
Toxic megacolon would be, without response, would be 72 hours. So these would be the colectomy patients. So that's UC. Fairly easy, I think, from the Q standpoint. Of all the things we do, this is one of the easiest. Professor Rourke, anything you want to add? Okay, let's talk about Crohn. I don't know if it's Crohn's, apostrophe Crohn's.
I learned this
I have-
yesterday, right?
I have seen it, I've looked it up. Okay, the American Gastroenterology, they go with Crohn.
Possessive, like Crohn's.
They do Crohn.
Well, because the doctor, we learned this,
Yeah.
the doctor, it was Crohn's.
So they gave the disease.
Should be either
So it looks like it'd be possessive.
Yeah.
Right, Crohn's disease.
But it doesn't have the disease.
And he only
He
got,
don't.
why did they Crohn's? Alphabetical order.
Kind of like when physicians are talking
He was for his
Say it again.
last name being C, he was first on the article,
Uh-huh.
so it's not Oppenheimer disease, it's Crohn's.
Ah.
They used to not cite the articles like we do now.
Yeah.
For like main contributors and all that. You just got first.
Well, what a disease to be named after. I didn't say it. Yeah, you got me. The approach is the same. You want to induce remission, and you want to then maintain them. Now, I put 2 approaches there in the beginning, step up or step down, or they use step up and top down. We use this same approach when we talked about steroids in asthma. Remember I told you that there's very few times where we start at the highest dose and work our way down? Usually we start low and we build up. Like with people with blood pressure, we don't just blast them, do we? Usually not. We start low and we titrate up. So with people who have mild disease, low risk, Crohn disease, we're going to use that approach. We're going to use a step up. For the people who are the sickest, they have moderate to severe disease, we are going to start with the big guns, and we're going to work our way down. Okay. So if you look on the next page, that lists what a low-risk patient with mild Crohn's would be. So let's take a look at those. So these are people that have very few symptoms. They're C-reactive protein, so their inflammation is low. They're usually older when they're diagnosed. Limited distribution of bowel inflammation, no ulceration, lack of perianal complications, no prior resects, and no penetrating, and that's stricture disease, sorry I put structuring. Okay, so that's our low-risk people, mild disease. Okay, so let's look over on page 19. Inducing remission in low risk. This is a difference. In the past, they used mesalamine. Now they go right to steroids. So, and the one that they like to use is Intercort. So that's usually the first step, is use a steroid that will deliver to that part. So Intercort is designed to deliver to the ileum. So these would be patients where you mostly have ileitis and maybe some colon involvement. So again, this one is 9 milligrams daily for 4 to 8 weeks. And then you start a taper. And their taper suggestion is 3 milligrams every 2 to 4 weeks for a total of 8 to 12. You will see other recommendations that go longer if the person is responding but not fully asymptomatic. But we're going to go with the 8 to 12. Majority of patients with mild, low risk are going to go in remission with that approach. Okay. So the recommendation is if they respond, you taper them off and they're doing fine, you leave them alone. You don't put them on anything else. You follow them with colonoscopy. An alternative is prednisone. Prednisone is very powerful. It will do the trick. But again, we're trying to reduce the amount of systemic drug that, or the systemic exposure is less with Intercort versus prednisone. Intercort can still put them at risk for adrenal suppression, but the prednisone will do it even more. Okay? But it is an alternative if they're not responding to the Intercort. Again, 5-ASA has been used, mesalamine has been used. Some people may do well. They may have been on it in the past and have responded well. Maybe they lost insurance, they've gone off of it, or they were off for a time. It would be a reasonable in mild people to consider that. It's just not, it's not the preferred, again, any longer. Diffuse colitis or left colonic involvement. Again, here it's steroid because it's more colon or more bowel that's involved. So here, because you are beyond the delivery method of that Intercort, you're going to have to go with prednisone. See the difference? Okay. And here's where an oral mesalamine may be of benefit as well, because you've got more, especially if you have more colonic involvement. So maintenance for the ones with more diffuse involvement is, again, tapering them off. Here it is, if you can taper them off and they do fine, it's watching and waiting. If patients have been on, if they achieved remission with the mesalamine product, you can leave them on it. So again, this is all mild, usually more localized for colon involvement. Adjunct treatment, just like we do with UC, if loperamide or diarrhea. Here you can use a bile acid. If they are having still a lot of diarrhea, you can use a bile acid. Probiotics, no support, even less than what we see with UC. Lactose avoidance may help. Eliminating other food triggers would help. If they're eliminating a lot of foods, I'd have them work with a dietitian. Okay. Questions about that? Okay, so let's look at high risk. So these are moderate to severe patients. These are usually diagnosed younger. So y'all didn't talk about high risk at all? Okay. Tobacco use, elevated, so more evidence of inflammation, C-reactive protein. Did you talk about fecal calprotect? Okay. Deep ulcers on colonoscopy, large segments or long segments of bowel involvement, perianal disease, extraintestinal manifestations. Realizing most of these drugs have disease process that's outside the colon or the GI tract. I didn't go into any of those. History of bowel resection, people who haven't responded to glucocorticoids in the past. Okay, so those are all high risk, makes sense. Here we're going to do top down. Here we're going to start with the biologics. These are like the big guns of Navarone. We talked about that movie. It's one of my favorites. Y'all ever seen it, The Guns of Navarone? It is so good. Oh man, you should rent it sometime and watch it. It's so good. Gregory Peck. Some of the old guys, they're so. Okay. So we're going to start with the TNF alpha. We're going to start with the biggest guns and we're going to blast them because we're going to get that immune system under control. So the TNF alphas, there's 3 of them, just like with UC, that we could also use. So infliximab's been around a long time. It's one of the common ones. Humira and Cimzia. So the same 3. They differ in how they're administered and how often they have to be administered. Glucocorticoids usually have a fast response, so they may also be used. They're very powerful. They'll induce remission much more quickly. So they're short induction. Think of them as a bridge. When we get to RA, we will talk about the same thing. Because they're quick and they're powerful, we can use them in the interim until our biologics can take effect. Again, because they're very powerful immune suppressants, again, TB, we need to rule that out before. We also need to be on alert for other tumors popping up or myelosuppression popping up. So they're hard on platelets, they're hard on white blood cells. So they're at risk for infections. Okay. Non-responders. These agents are new. Stelara is, I hear commercials for them. I'm amazed they do commercials because it doesn't have that big of an audience. But anyway, this is that anti-leukin 1223. It is one of those more last resort. So if the TNF alpha didn't work, this is another group. Works on T cells, different part of the immune response. Next page, Entyvio, another one, commercials are out there about it. It's another this one's an anti-integrin antibody. So they just affect the immune system in a different way. So these are, I doubt unless you are dealing in GI with these folks that you would ever start these at this point. But you may have people on them and come into an emergent area that you would need to know about. I think in your lifetime the biologics are just going to explode. It's amazing how many have come about in the last 5 years. So I think we're going to get much more targeted and we're going to get much more target, less toxicity down the road. Maintenance, these folks are going to have to be on biologics probably long-term, probably lifetime, to maintain their remission. That's about it. To me, Crohn's is harder, but I think it is in change. In terms of in figuring out where these biologics will work and what ways are going to work best. Questions? Yes?
Is there a specific percentage that you know of patients when they're on anti-TNF drugs have developed tumors?
Oh, not off the top of my head.
Okay.
I would say it's low. The thiopurines are high.
Like 1 in 10,000. Okay.
Yeah, the thiopurines are much more likely to do that.
And does that happen too with like the anti-leukin?
Off the top of my head, I do not know. Anything you want to add?
I have a question.
Yes.
Would you use for a hospitalized Crohn's patient, would you also use prophylactic heparin? Because I know he talked about they also are at risk.
Yes, yes, you should.
Okay.
Anything else? I will see you guys on Tuesday then. And we'll have, I will have your, let's see, I'm getting ahead of myself with renal and GU. Because I'm going to be out for about 10 days, I'm going to have those ready for you, and I'll bring the prescriptions, so I know it's ahead. but I won't be here when I would have actually done them. And I'll also get them posted to YouTube. All right, have a good weekend.
And I'll go open Pharm West now. If anybody would want to go there and practice.
Thank you.
I'll go open it now.
I need that now. I sent you both of them.
Okay.
I'm like going to the surgery. I'm so hungry right now. I'm working on it. Yeah. I wonder if my I have a face